Welcome back to UC Davis Live COVID-19. I'm Satirius Johnson, and this week I'm talking to two UC Davis clinicians, medical doctors who have been part of the team treating COVID-19 patients. We'll be talking about what they've learned in the past 2 months and what new treatments could be on the way. Dr. Stuart Cohen is professor of internal medicine and chief of the Division of Infectious Diseases at UC Davis Health. He's been deeply involved in treating COVID-19 patients, including some of the first use of the drug Remdesivir. Dr. Sarah Barnhard is Director of Transfusion Medicine and Assistant Clinical Professor in the Department of Pathology and Laboratory Medicine at UC Davis Health, and she's part of a new effort to use blood plasma from recovered COVID-19 patients as a treatment. Thank you so much for coming on today.
Thank you.
Thank you.
So we are taking your questions. If you're watching us live, please leave any question you might have in the comments section, and we'll work in as many as we can. So let's start with an overview. Dr. Cohen, when a COVID-19 patient is admitted to the hospital, what can we do for them? What are the treatment options right now?
So much of it depends on how sick they are. But as a global way of looking at this, most of our care is the type of supportive care that we would give anybody with a respiratory illness. So we supply oxygen, we make sure they're well hydrated. We do the best to keep everybody comfortable, manage their fevers, manage the other symptoms that they have, and not necessarily give antiviral drugs like we would for some illnesses, or as people are more used to with antibiotics for pneumonia. We don't necessarily do that with everybody that's managed. And if the patients actually are very ill, they need to be in an ICU, and they need to be put on mechanical ventilation to help them breathe. But all that is what we would consider standard care for somebody with a respiratory illness.
Why wouldn't you put someone immediately on an antiviral?
Well, at this point, we don't have antivirals that are FDA approved and are demonstrated to be clearly efficacious in all patients that have COVID-19.
Back in February, you were involved in treating a patient who was at the time, he was thought to be the first case of coronavirus contracted by community spread in the US. What did we learn from that case?
Well, there were a couple things that we learned, but most important was the fact that it was present in the community. And I think at that time, there were some difficulties in the ability to get lots of tests. And so the criteria for testing was very, very stringent and included having a travel history. And so our patient, who was the first community-acquired disease in the United States, or at least the first documented community-acquired disease in the United States, sort of opened the door for the idea that people could pick it up here and you didn't have to be coming from China in order to end up getting infected.
You know, you mentioned that we don't have an FDA-approved drug yet for this new virus, but there is a new drug, Remdesivir, that we were hearing about a lot in the news. The FDA has approved it for compassionate use. What is compassionate use, and how is that different from a clinical trial?
So compassionate use is you take a drug, and let's use Remdesivir as the example since that's what you brought up. So we know in the laboratory that Remdesivir is very active against coronaviruses, not just the coronavirus that causes COVID-19, which is called SARS-CoV-2, but other coronaviruses, including cat coronaviruses and other species. So it was thought that this might be a good choice for treating people. And when there are no other options in patients who are so ill that they're likely to die, the pharmaceutical company through the FDA is able to provide this medication for compassionate use, meaning compassion, right? We're trying to do anything we can do for these people at the end. And that's the first option. But it's not a clinical trial because there's no randomization. It's basically if your patient meets their criteria, you can treat them, and outcomes are just individual anecdotes. So you can't necessarily take from that information whether this drug would really work because you don't have a group that didn't get treatment. And so you don't really know whether this would have been the same outcome if you hadn't treated them versus treating them. Is that clear?
Yeah, I think so. I mean, so it sounds like it's kind of a therapeutic Hail Mary pass, and that you're weighing that the risks are not greater than the possible benefits.
There you go. I think that's a good way to look at it.
So what exactly is Remdesivir, and how is it being used right now at UC Davis Medical Center?
So Remdesivir is an intravenous medication. It works to block the replication of the virus. So SARS-CoV-2 is what's called an RNA virus. So that's the genetic material of that virus. And in order for it to grow, it has to make more RNA. What Remdesivir does is it stops the virus from making more RNA and therefore stops it from growing. The current use of Remdesivir at UC Davis now is that we've been part of a National Institute of Health clinical trial that compares Remdesivir with placebo. And that's some of the information that's already been released via press release. And the data are being compiled and being prepared for submission for a journal publication. And that trial is sort of finished. And therefore, we're moving on to the next trial, which will be Remdesivir versus Remdesivir plus another medication called baricitinib as the second phase of that clinical trial. So once again, it's randomized, but there's no more placebo group involved. Remdesivir is going to be given to every patient in the trial.
And I believe you and your colleagues are also testing another drug called serolumab. What does that do? How's that different?
Serolumab is what's called an interleukin-6 inhibitor. And so what that is when your body goes to fight off an infection, your white blood cells send all kinds of signals out. Those signals cause the inflammation that allows your body to control these infections. Sometimes that inflammation is overzealous and is part of the disease process. And so one of the things that people may have read about or heard about in the when people report on COVID-19 is that the patients undergo what's called a cytokine storm. That's these hormones that our body makes to try to trigger an immune response. Interleukin-6 is one of those chemicals that helps in triggering this cytokine storm. And if part of the disease is related to that immune response, trying to calm down that immune response without totally stopping it is the strategy. So as opposed to a drug like Remdesivir, which stops the replication, a drug like serolumab is actually there to cut down the inflammatory response and control the disease in that way.
Can you tell us anything about how these trials are going? Are there any kind of early indications as to the direction?
Yeah, so with the Remdesivir trial, I think the one thing, sorry.
Okay.
I turned off everything else, but not that. So with the Remdesivir trial, the preliminary data that have been publicly available is that it's shortened the duration of hospitalization and patients on that clinical trial by about 4 days. And the way this study was done is sort of like a lot of the respiratory studies are done. There's 8 steps that people get classified in. And if they get into one of the top 3 steps, which is they can either go home feeling perfectly fine or go home feeling good but not back to baseline, or not go home but would be able to go home except for infection control issues. So if they had to go to, for example, to a skilled nursing facility or something like that, those are what are considered the successes. And that's what we were talking about when we were saying that that's the 4-day improvement. As far as mortality rate, the mortality rate was lower in the remdesivir group too, but it didn't meet statistical significance. There are still data that are being analyzed to finish the study off, because this was a study that was reviewed by what's called a data safety monitoring board that said the data should be presented before all the final information was in.
So it sounds like it's promising, though. I mean, it's very promising.
It is promising. I think it's the first step towards developing treatment. I'm not sure that this is the ultimate answer, but I think it's a step in the right direction, and it demonstrates that we can do something about the infection.
Dr. Barnhard, you're treating patients with plasma from people who have recovered from COVID-19. Plasma is part of what makes up blood, but what makes it so special?
Plasma is special because it's the liquid portion of the blood where all of the proteins that are in the blood itself are soluble in the plasma. The blood that we have in our body is a mixture of cells and soluble proteins. And if you centrifuge blood, it actually separates by its components. This is where soluble proteins are. So you can separate blood between the cells, which are the red blood cells, and the plasma. Convalescent plasma comes from donors who have previously had a COVID-19 infection and have healed from that disease. And if you take their plasma that now has mounted an immune response against the virus and transfuse it to patients, the theory is that you would help those patients recover from their disease more quickly.
And how successful has this approach been in treating other diseases?
With convalescent plasma, in order to have a stable supply chain in place, you have to have a pretty significant amount of plasma donors. And so we are still in the very early stages of clinical trials related to convalescent plasma, because we need the donors to have healed from their disease for at least a month, 28 days. So many of the initial trials, like Dr. Cohen was mentioning, involved various pharmaceutical agents, whereas convalescent plasma is relying on a large portion of the population to have been healed from their disease for at least a month. So we're still in the very early stages of clinical trials across the country related to convalescent plasma.
Early stages for this novel coronavirus, but has this approach been used with other diseases with success?
It has, with variable success, I will add. Using convalescent plasma is certainly not new. It's been used for decades with other diseases, including Ebola, some of the other coronavirus outbreaks. Some of it has had very controversial and likely minimal effect on the disease of the recipients of the convalescent plasma. But in some cases, such as the other coronaviruses, including SARS-CoV-1 from 10, 15 years ago, it did seem to improve the mortality outcomes in the recipient population.
And this convalescent plasma for COVID-19 is being used under what's called an expanded access protocol. Is that kind of similar to compassionate use like we're seeing on the medication side?
It's similar. Oftentimes with compassionate use, you have a specific patient that you're trying to advocate for. And so as Dr. Cohen mentioned, you notify the pharmaceutical company and they work directly with the FDA in order to have access to therapy for one patient. What's unique about the expanded access protocol is that Mayo Clinic worked very closely with the Food and Drug Administration to allow national access to convalescent plasma. There are very specific enrollment criteria for who the recipients of the convalescent plasma may be, and those are listed in the Mayo Clinic protocol. But because they did all of the legwork across the country, any hospital that has patients who fulfill their criteria are able to enroll their patients in this expanded access protocol and have access to convalescent plasma. It was a wonderful effort on the part of the Mayo Clinic, and a lot of people are very grateful.
That's great. We are taking questions. If you're watching us live on the live stream, you can drop any of your questions in the comment section and we will work in as many as we can. We do have a few coming in. Celia on Facebook is asking, what are the side effects of Remdesivir?
So it's been surprisingly side effect free when you compare it to, again, a placebo group of people who are just very sick. The one thing that seems to happen is that liver function tests become slightly elevated. So there's maybe a little bit of inflammation in the liver, but that seems to resolve after a day or two. Beyond that, I don't think that there's been much difference between the patients that have received Remdesivir and the placebo group.
We have another question. Stephanie on Facebook is asking, are there any treatments already available or in the process of being developed for the children that are becoming sick due to COVID-19? Is Remdesivir going to be used to treat kids as well?
Yeah, so Remdesivir is available through through an expanded access program, similar to what Dr. Barnhard was talking about with the plasma, for children and pregnant women, which is separate from clinical trials. So they all get treated in that setting.
Turning back to the use of convalescent plasma, and this is for either one of you, I guess, maybe both. Would people getting that treatment, would they also be able to be treated at the same time with medications like Remdesivir?
Yes, it sort of depends on the institution because there are various clinical trials that have been opened across the country, and Dr. Cohen certainly would know the ones that are active here on our campus site. Some of them may have exclusion criteria related to convalescent plasma, but my understanding is that very few will say you can only receive a medication or you can only receive convalescent plasma. Oftentimes they allow therapy with either intervention.
Yeah, I think a lot of it depends on what you consider standard of care for some of these clinical trials. Because as long as standard of care is followed, they allow you to use these other medications. I think in the big picture, probably unless something more more efficacious, more effective than what we're seeing is out there, I suspect that some type of combination of treatments is going to be necessary for patients.
We have another question. Tommy from Facebook is asking, what's the best way to find out if you have the antibodies so you can donate plasma?
Yeah, that's a great question. One of the barriers that we've run up against since day one in trying to develop a stable supply chain for convalescent plasma in the country is that the initial patients or individuals that were infected with SARS-CoV-2 did not have access to testing early in their disease process. And because of that, we don't have a confirmed positive test result. And in order to donate convalescent plasma, we need to prove that they actually had that infection in the past. So we need to do antibody testing on them. Many blood suppliers are rolling out antibody testing for population screening purposes in the blood supply. So I would definitely recommend individuals who are interested to reach out to their local blood supplier and ask if that's a possibility. If not, they could reach out to their primary care physician and mentioned that they had an infection that seemed very similar to what the infection is with COVID, and they would like to be tested for antibodies against SARS-CoV-2. There are various testing platforms being rolled out across the country. UC Davis, we do our own testing here on site as well, and many hospitals have acquired that ability. So it's becoming more and more capable in the population of doing that testing.
And I think there are some companies there's some researchers out there who are trying to graft part of the human immune system onto like cows or mice to create that plasma as well. What do we know about that, and how promising is that kind of research?
Yeah, it's a great question. We've used animal models in the past to try to develop different medications, or even create some sort of a universal blood that we could transfuse to people. It's very challenging working with animal models because oftentimes the human and the animal don't mix well. And so you have a pretty decent amount of research and development that has to go into developing some sort of an animal model that is capable of treating a human. Humans can make antibodies against the antibodies that you give them that come from an animal source. And so sometimes all of the effort and development that went into developing the medication is sort of all for naught, because people develop immunity against the drug that you're trying to treat them with.
So for the time being, we are dependent on human donors.
We are, yes. At this time, we're dependent on humans.
We have another question from Facebook. Beloved, watching us on Facebook right now, is asking, in your opinion, is a COVID-19 vaccine necessary?
So I think that it would be a very good thing. Let's say it that way. I don't know whether it's absolutely necessary, but I think that most people are getting tired of wearing a mask everywhere they go or sitting at home all the time. And I think this is one way to immunize the population to the point that we have enough immunity that the virus transmission sort of peters out. You guys have all heard the term herd immunity. And what that means is that whether through natural infection or through vaccine, once over 60 or so % of the population becomes infected, then the virus doesn't necessarily have the same targets. And so the ability of it to be transmitted and the rate in which the cases will rise will be much less, right? And so we use vaccines for influenza. We know that flu vaccines are far from perfect, but we also know that it saves lives. And I think that this is the same idea here. I don't know that we're going to get a vaccine that's as effective as the measles vaccine was, or that will eradicate the disease like vaccines were able to do with smallpox. But clearly this will help us move along from where we are right now as far as the ways that we can prevent infection, which right now is just keeping our distance and washing our hands and wearing masks.
And I guess, you know, when we hear of the kind of the course of a virus's spread and, you know, viruses quote unquote going away, it's because we get that herd immunity, and the safest and most the safest way to get there is with a vaccine with the least death and the least illness. Is that correct?
Yeah, I think that's a pretty good way of saying it.
Mm-hmm. We have another question. Israt, who's watching on Facebook, asks, some people are being treated with hydroxychloroquine, or let me do that again, hydroxychloroquine, methotrexate, and folic acid. What are the chances for recovery if they've got the virus? That's kind of a hard question to answer, I guess, really case by case basis, right?
Yeah, so hydroxychloroquine is also an immunosuppressive, similar to what you were talking about with serolutamab, and is also has some minimal antiviral activity itself. So it just in the way the virus multiplies, it does impact it some. And methotrexate is another immunosuppressive medication, and folic acid is given with methotrexate in order for people to not get very anemic. The problem with all those treatments right now is that there haven't been good randomized trials to demonstrate there is benefit or not. There clearly are some potential toxicities with hydroxychloroquine, particularly the heart toxicities. And so, at least in my perspective, at this point in time, the best way to ever figure out what's going to really work for this is to do everything in some form of a clinical trial, so that by the time this first phase of illness is over, if we're going to see a second phase coming on in the fall, that we'll know what we're doing. We'll know more then than we knew at the beginning of March. And I think by just randomly treating people with one thing or another, you really don't get there. That's one of the problems.
Dana on Facebook is asking, is there fear of a shortage of remdesivir?
Well, I don't think that they had planned on the volume of remdesivir that they would have to make in order to address this problem. Just by way of perspective, this drug was actually tested for Ebola and didn't work back several years ago when Ebola was running it wild in Africa. And so they had stocks of this drug already prepared before COVID-19 happened. Now they have to start ramping up their ability to make it, and I'm sure they're capable. Whether they can keep up with the demand is not for me to say. I don't work for Gilead, so I don't know.
Diana from Facebook is asking, what's the progress on serology tests to accurately identify the antibodies in recovered people?
I can start. I'll let Dr. Barnhard finish up. So the serologies are perfectly good tests for the most part. I think this is a little bit of a tricky concept to explain, and so I will do my best. So these tests are very sensitive. So pretty much they won't miss a lot of people who have been infected, but they're very specific, but not perfectly specific. And so that means that, let's say 2% of people who are tested will have positive tests that shouldn't be positive. But then if you go into a population where there's only a small number of cases, that 2% becomes 50% or more, because anybody who's positive, right, if you use these antibodies before this outbreak happened, anybody who was positive would be a false positive test. Right now in our area, for example, I think the prevalence of COVID-19 is small enough that there are many, many people who would have positive tests that wouldn't necessarily demonstrate immunity. Somebody actually had disease and then they had a positive test, that's terrific. But I think just putting it into a population right now, we run the risk of falsely predicting that people would be protected when they're not. And so the tests just have to be tweaked a little bit more to make them a little bit more specific. And then I think there'll be a good way to do prevalence testing, so determine how much disease is in the population, and also try to help people figure out whether they're immune or not.
Yeah, and I'll just add as well that from the blood donor screening perspective, it's important to understand not only is the antibody there or not, but how much of it is there, we call that a titer is the medical term for that, but how much of the antibody is present. And also whether or not that antibody can adequately control the virus itself. And we call that a neutralizing antibody. And some of those additional assays being able to run not only the antibody and say yes or no, is it present, but be able to say how much of it is there so that we know that we're dosing with convalescent plasma therapeutic dose, but also whether or not that antibody is truly going to control the virus. And those are probably two of the biggest barriers at this time to being able to screen the blood donors appropriately.
I have one more question from our audience. Anthony is asking this question for both of you. What is giving you hope in your research?
I guess I will start. I'm optimistic. I think that we've seen some major strides forward. I think just the plain out clinical management of the patients has gotten significantly better. Over time, I think people understand a little bit more as to how the disease progresses and are able to more effectively address that. But in addition, I think Remdesivir is a step forward. It may be a baby step, but I think it's a step forward. I think that there's a big, long pipeline of drugs and of other therapeutics that are available. And I think that there's a willpower to get this done within the medical communities. And so I think there are a lot of positives. And I think that it's been, as everyone has said, right, it's very impressive. We've really pulled together as a medical community, I think, and addressed what is the fourth pandemic that I've been in, but this is the biggest one, and this is going to be a major change to all of our lifestyles. And I think that we've really made our way positively.
Sarah?
I agree. I think the biggest thing that gives me hope is the amount of collaborations that this reaching out and trying to meet the needs of the patients, the number of collaborations that this has given us, not only here at UC Davis, but across the entire country and in some ways the world as well. Having all of the minds on the planet come together to think about how to treat these diseases and how to approach them in new ways is ultimately what gives me hope. Specifically to convalescent plasma and transfusion medicine, we have yet to really develop a medical therapy that is equivalent to the human body. We have very little capability of harnessing biologic capabilities. We're starting to in some ways for things like CAR T therapy and other therapies for cancer therapy. But the power of the human body still supersedes everything that we do in human medicine. And being able to be on the forefront of collecting plasma from people who have healed from this disease and being able to administer it in a safe way to people who need the passive immunization to be able to fight their own infection is definitely practical in a way. I really do hope that what comes out of this is being able to show whether or not we did influence the disease trajectory for individual patients and how useful convalescent plasma is. There are safer ways of affording passive immunization, including things such as hypergamma-globulin, being able to concentrate the antibodies and turn it into a pharmaceutical agent, essentially, and it doesn't carry the same risk of actual transfusions to individuals. And I think that we'll see more of that development as well in the future. But ultimately, what gives me hope is just knowing that we have more communication, more collaboration for the future events when this type of a pandemic hit us again, which I'm sure that they will at some point in the future, and that we've learned a lot from what we're going through now, and we're better prepared in the future for another global crisis.
Well, I have to say we're getting a lot of messages of support and gratitude for you both, and thanks for the healthcare heroes like them. So before we go, we often see a lot of hospital staff holding celebrations when COVID-19 patients leave the hospital. Is there a great feeling of relief when you get to see a patient go home healthy?
Yeah, I think right. I think that if the expectation, particularly somebody who comes into the ICU needing mechanical ventilation, it's a great success. I mean, we look at that for patients that are not COVID-19 patients as well, right? I think that's what our jobs are to impact people's lives and to make things better for the patients. And so, of course, we're happy when that happens.
Yeah, it's a job and a calling. I think that it's incredibly fulfilling, and we feel very lucky to be able to be here and helping people survive and maintain health in new ways. Saving lives. It's what keeps us going.
Dr. Sarah Barnhard is Director of Transfusion Medicine and Assistant Clinical Professor in the Department of Pathology and Laboratory Medicine at UC Davis Health. Dr. Stuart Cohen is Professor of Internal Medicine and Chief of the Division of Infectious Diseases at UC Davis Health. Thank you so much for coming on today, and thank you so much for all your great work.
Sure. Thank you.
Every other week, we'll be hearing from researchers from across the UC Davis campuses who are working on vaccines, therapies, and medical devices, tracking the virus and looking for solutions in unexpected places. On the next UC Davis Live COVID-19, we'll be talking about testing for the virus, the different ways of doing it, what the results mean, and how they're being used. That's coming up in 2 weeks. Until next time, I'm Saturius Johnson, and this is UC Davis Live COVID-19.